Okay. And then the video you will Yes. Thank you.
So thank you. This morning I'm the substitute of Nikos Lavropoulos due to Sandy hurricane. So let's start to identify what is exactly CCSVI. Recently, this acronym has become famous in the non-scientific press and in the social network, considered as a revolutionary hypothesis in the pathogenesis of multiple sclerosis and consequently on its treatment. The definition is the one given by Zamboni in his very first paper, the presence of multiple severe extracranial stenosis affecting the principal cerebrospinal venous segment, which provide a picture of chronic cerebrospinal venous insufficiency. In reality, if the name is new, the concept is not new at all. This concept, in fact, has been proposed many years ago, and CCSVI represents a kind of reprisal of interest for a condition which is potentially effective in determining and worsening the symptomatology in multiple sclerosis. In 1973, in Paris, a group of neurosurgeons brought about a possible role of alteration on demyelinizing disease, and they provided an open operation, on a series of patients opening jugular veins. Unfortunately, the result seems to be good on a clinical side, but not good on the surgical one, mainly due to the aggressive venous surgery of that period. In 1986, Schelling described extensively the possible role of venous reflux and hypertension in multiple sclerosis, and maybe this work has been undervalued. But although these authors are very important and highly represented, there is a number of papers describing the interest of venous system in multiple sclerosis until 2009, which is the year of the appearance of the first work of Zamboni. Up to the present, there is a number of papers, both of high and low quality, that has been published, and many endovascular procedures has been performed, frequently poorly documented, and while extensive anecdotal records are present on the web, if we research CCSVI on PubMed, we have 100 results. If we Google it, we have 1 million of results. What is important to underline is the lack of knowledge about venous anatomy and physiology, the application of inadequate endovascular techniques, and frequently an incorrect methodological approach have strongly affected the outcome. Let's know something about the anatomy of this system. The main extracranial vein involved in the cerebrospinal venous drainage are the internal jugular vein, the vertebral vein, and the azygos system, which is the most important way of correlation between the two cava systems, inferior and superior. The internal jugular vein presents a bicuspid valve in 90% of cases, which is common. It may be hypoplastic, less than 5 millimeters in a number of cases. And there are physiological elements that are able to reduce physiologically the internal jugular vein caliber, which are mainly the standing position, the homolateral neck rotation, the anatomic structure of the neck, like the carotid valve, and the blood mass of the patient, the hydrostatic balance. The azygos system is usually originating from the confluence of the ascending lumbar veins. Usually there is a valve on the superior cava junction, and this system has frequent anatomic variation. Can this alteration in venous draining system determine a clinical outcome? This is the first question we have to answer. In the inferior cava system, we know exactly that there are many situations that determine a clinical variation. May-Turner syndrome determines symptoms to the left limb. Nutcracker syndrome is able to determine and impair the kidney drainage, determining pain and bleeding. Post-synoptic syndrome is the most frequent cause of venous lesion in the leg. So we know that venous lesions in the inferior cava system are able to produce chronic venous insufficiency. In the superior cava system, where we have the obstruction of the superior cava brachiocephalic veins, more or less extended to their tributaries, due to different etiology, mainly malignancy, we have a specific clinical presentation, which is the superior cava syndrome, That is absolutely important from a clinical point of view. So, if we ask, can alteration in venous draining system determine a clinical outcome, we have to say yes. These alterations are able to determine clinical outcomes which are featured by specific symptoms. So we can advocate a kind of pathological cascade where there is evidence on causal effect between venous anomalies and clinical outcomes. Consequently, there are strong recommendations to treat those lesions in symptomatic patients. Iliocava standing in PTS, deep venous reconstruction in flux, a correction of superior cava syndrome when necessary. So next question is arising. Is CCSVI related to specific symptoms? Keep in mind, while chronic venous insufficiency and superior cava syndrome are characterized by specific symptoms and clinical alteration, CCSVI consists in a number of ultrasonographic findings, not in a clinical scenario. CCSVI is described as more or less associated with MS. There are lots of work for example, in this one, we have more than 90% of association, or contra with Barachini, which say there is zero association. Multiple sclerosis itself may present in various symptoms, non-specific, depending on the location of the neurological lesion. So is CCSVI related to specific symptoms? No, it is not. It describes a number of venous lesions that are held to determine the impaired cerebrospinal venous drainage. Given that CCSVI is described by the occurrence of venous lesion, mainly stenosis, what are exactly the criteria defining the significance of those lesions themselves? It is a very important question to answer. Stenosis in vein cannot be defined as a percentage reduction of caliber as for arteries, because the vein diameter is variable itself. I have some problem with the video, so we run on the photo. Consequently, the definition of vein stenosis must be functional and not anatomical, based on data that are detected by the available diagnostic methods. For example, ultrasound scanning can detect the absence of the reduction of flow. And consequently, venography can be used for evaluation. For example, there are some data, some contrast dye persistence and findings that can be used to verify the presence of stenosis. High usage may be important in discriminating false positive and false negative. Considering that in the literature the identification of significant venous anomalies ranges from near 0 to near 11, we are obliged to near 100. We are obliged to assume that the criteria actually defining CCSVI are still not unequivocal. We can make an hypothesis similar to what happens in the inferior cava system. The presence of collateral pathway may be an indirect indicator of stenosis. Can I have help for the video, because now it's important. In this video, we see how, okay? This can be the image of a normal internal jugular vein. Okay, back to the presentation. So it may be better to go to the video. So we can have the alteration or the activation of collateral pathways that can be very impressive. Now maybe we see at the end there, otherwise we lose too much time. In this case, there will be an external and internal jugular vein involvement. a contralateral involvement of the internal jugular vein when we see the contrast medium that instead of going down in the correct side, go down, passing through the brain and go down in the contralateral internal jugular vein. Or we can have impressive variation or activation of collateral pathways in the azygos system that involves the intrarachidian plexus. But whether those hemodynamic scenarios are pathological or have to be attributed to individual variability has still to be evaluated. And if this alterated cerebrospinal venous drainage is able to determine a clinical outcome is yet to be demonstrated. That's an important point. So the treatment of CCSVI, despite it can be impressive from a radiological point of view, has to be performed in very careful situation. There is no rationale today for the stent used in internal jugular vein, and some kind of open surgery that unfortunately we have seen must be strongly discouraged, because they can be held to risk of reflux disease that has already been described and which are linked to a massive valve destruction. Possibly the future of CCRVI will be the repair and reconstruction of valve in the internal jugular vein, not in the extraction. So I think that undoubtedly, thanks to CCSVI, the scientific attention has been drawn to a part of the venous system usually neglected. This event opened the door to future research and opportunities. A number of venous alterations have been identified, but their occurrence has to be explained, as well as their possibility to determine a clinical symptomatology. On the other hand, it is at the present arbitrary to establish a causal relationship between CCSVI and MS, and consequently possible operative treatments have to be performed under rigorous controlled conditions. Thank you.